speaker, who is Twila Brase. She was named Minnesota's 100 most influential healthcare leaders. She is an emergency room nurse and also a certified public health nurse. Now, most of you know that, for whatever reason, those of us who are in medicine don't know a lot about public health, and those of us who are in public health deal with epidemiology and don't know a lot about real-life practice of medicine. She has provided statements and testimony to state legislators, federal committees, and she has appeared on state and national television shows and radio shows. Most important, December of 2008, she published a report on evidence-based medicine, and she's going to talk to us on this topic. Please help me welcome Twila Brase.
Thank you very much, and I'm very happy to be here. I cannot remember if Dr. Brege mentioned that I'm president of Citizens Council on Healthcare as well. So we are a state healthcare policy organization, but we also work on national policy. So a little bit of what you're going to hear today about evidence-based medicine will be, or actually most of it will be national. It will not be regarding what's happening in the state of Minnesota. Well, as you all know, with regards to healthcare, we have a problem. We have rising healthcare costs. We have the impending Medicare insolvency in 2017. We have rising uninsured rates, and we have employer-sponsored coverage eating up wage increases, to name just a few. The list could go on. Into this mix comes evidence-based medicine and the call to require doctors to provide to patients only the care that is evidence-based. So what does evidence-based mean? Evidence-based medicine was defined by Canadian David Sackett to be the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. In theory, this sounds good, but is it? The gold standard in evidence-based medicine, or EBM for short, is the randomized clinical trial, which takes years to complete and typically costs $50 to $100 million per trial. Most treatments today do not have randomized clinical trials backing them. The secondary standard in EBM is meta-analysis, essentially a systematic review of research studies already completed. EBM is increasingly combined with pay-for-performance initiatives, including so-called measurement of quality and value-based purchasing. Doctors who practice evidence-based medicine, as defined and measured by health plans and/or government agencies, are rewarded with financial bonuses and higher incomes. Those who do not are penalized. EBM is also part of the new American Recovery and Reinvestment Act that was passed just recently. The Act provides $1.1 billion for comparative effectiveness research and $19 billion to set up a national health data system to enable this national research project using government access to private medical records. If this initiative moves forward as planned, we expect that we will all become research subjects for the purpose of determining which treatments have evidence of effectiveness and which do not, and thus which treatments will be paid for and which may no longer be available. But will this proposed nationwide practice of standardized medical decision-making perfect the practice of medicine, or will it interfere with patient care? Will it make doctors better doctors? Will it meet the individual needs of patients? Will it bring the practice of medicine to new levels of high-tech diagnostics, medical sophistication, and maybe even an end to cancer someday in our future? The answer, I believe, is no. After spending a significant amount of time researching the topic, let me share with you a few concerns about evidence-based medicine and standardized medical decision-making that you may not have considered. The first concern is science. Science is probably not what you think it is. That's the first and most important realization. Whenever people support evidence-based medicine, the first and best question that you should ask them is, whose evidence? Although supposedly based on science and scientific studies, the evidence used to produce evidence-based treatment protocols is not without controversy. As Harvard professor and physician Gary Belkin, the author of the most extensive expose on evidence-based medicine, notes in his paper, quote, "Scientific techniques that people see as objective proof, when more carefully examined, are easily seen to be the result of a multitude of subjective choices. Those, end quote. Those choices include what to study, what research questions to ask, who to include, and what information to review for the research. In addition, as the Institute of Medicine wrote in 2004, and I quote, "There are gaps and inconsistencies in the medical literature supporting one practice versus another, as well as biases based on the perspective of the authors, who may be specialists, general practitioners, payers, marketers, or public health officials," end quote. Remember the studies that found butter bad and margarine good. And then a few years later, butter was good and margarine was bad. Who funded these studies? Which ones should we believe? Are either of them true? In 2002, in one of the clearest indications of just how limited research findings can be, one large hormone replacement study significantly contradicted the results of another large and long-standing hormone replacement study, forcing doctors to reconsider their treatment of women. As Dr. Isaac Schiff said to the New York Times, quote, "If there are such discrepancies, how many other medical facts do we believe based on one type of study or another type of study because we don't have the luxury of having both?" End quote. Dr. Sidney Goldstein, a cardiologist from Michigan with 41 years of experience conducting clinical trials, spoke on the subject of evidence-based medicine and the limits of scientific research at our organization's annual event several years ago. People in clinical trials, he said, can be significantly different from the people who show up in doctors' offices. He displayed PowerPoint charts showing all the people who were eliminated from participating in his clinical trials for one reason or another. Yet he reminded us that people just like them will need care for the study condition, but for which people just like them were not allowed to be part of the study. Concern number 2, comorbidities. Now the doctors in this room know what this is, and some of you do as well, but comorbidities is a technical term for multiple health problems in one person. So let's consider people with diabetes. For example, person A is a 60-year-old with diabetes and heart disease. He recently broke his hip and is hospitalized. Person B is an 85-year-old woman with diabetes, macular degeneration, and depression. Person C is a 50-year-old. He has diabetes, asthma, Lyme's disease, and works nights, 5 days a week. Person D is a 13-year-old with diabetes and a really bad attitude. Now consider, guideline development company X has produced an evidence-based guideline for the treatment of diabetes. Do you think this one guideline will meet the needs of all these patients? Consider, too, that patients are as different as their DNA. Increasingly so, we will find this. They vary by physiology, gender, attitude, emotional strength, mental capability, willingness to comply with doctor's orders, adaptability, financial and cultural differences, risk aversion, fears, religious beliefs, drug allergies, susceptibility to side effects, personal preferences, and individual behavior, to name a few. Can one standardized treatment protocol meet the uniques of every patient? If not, how many different guidelines might be needed? Okay, concern number 3, outdated guidelines. By the time a treatment guideline is published, it can already be out of date. Guideline development is an expensive, time-consuming process, but medicine does not stand in place. It innovates quickly. One study of a major guideline development company found 75% of the guidelines in need of updating. The researchers also found half of the guidelines outdated in just 5.8 years. Another study found that only half of the guideline organizations have a formal procedure for keeping guidelines up to date. In another study, only 9.2% of 217 drug therapy guidelines were considered sound without need of modification. The National Guideline Clearinghouse now has more than 5,899 guidelines. There are, for instance, 360 cardiovascular disease guidelines, which vary in focus and size, ranging from 2 pages to 211 pages. Often these guidelines conflict in treatment recommendations. Which one should the doctor use? And how many are out of date?